Thank you, Dr. Lawton. Thank you for having me here. I wanted to spend time talking about medical therapy here. It's so important, and so I'm going to emphasize that as the non-surgical management, as much as I will say that PCI continues to be an alternative to our patients, and I'll speak about that briefly as well. These are my disclosures relative to the work in medical therapy, research grants, as you can see, primarily for my work in medical management and non-surgical approaches. So when we talk about the heart team approach to coronary disease, often the clinical cardiologist is left out. And this is really, really important because we have to keep our eye on the optimal medical management. We talked about this. I won't overemphasize it, but say that it is the cornerstone of therapy. And so we need to optimize therapy. What do we call optimized medical therapy? What really are we talking about? This is where we can get the systolic blood pressure less and blood pressure around 130/80. And so there's evidence that lower blood pressure is better epidemiologically, but for patients with extensive coronary disease, we need perfusion pressure. It actually comes from diastole. But the fact remains that it looks like the optimal blood pressure, 130/80. LDL less than 70, we're moving less than 50 now in many of the guidelines. But if we can get less than 70, that is awesome. But we have newer therapies I'm going to talk about. And if patients have, with regards to glycemia, is the A1C less than 7%. These are all the targets that we really define as optimal medical therapy. Now, the issue is, we talked about the three important subgroups, the triple vessel disease, particularly triple vessel, diabetes, LV dysfunction. These are the patients for which medical therapy is even more important. And I just want to put a plug into some of the newer drugs, the SGLT2 drugs, which are now being used in left ventricular dysfunction. I'm going to talk a little bit about those therapies now. The issue we have with our patients is set up in this slide. And I love the old box too here, but the idea is patients will spend more time getting their dog on a treadmill than they will themselves. This is human behavior, psychology. And the other thing that really bothers me is my patients always stop the last drug we started. And if it's a drug-eluting stent and they stop thienopyridines or clopidogrel or ticagrelor, it's a real problem. So the idea is we're dealing with human frailty here, and we need to always understand that. So get to know your patients and get to understand what really is underneath them. The idea here, I'm going to talk a little bit about blood pressure now. We need to customize blood pressure therapies based on whether patients are post-MI, where we will use beta blockers, ACE inhibitors, patients with diabetes, again, ACE inhibitors, ARBs, and we also use calcium channel blockers. Those, if they have chronic kidney disease, many of our patients do, and whether they have heart failure. And so the idea is we need to customize blood pressure, but I'm going to show you some data that's really compelling about where the target really lies. This is data from the INVEST program. This is actually an observational study from a randomized trial looking at tight control, less than 130 systolic, usual control 130/140, and out of control greater than 140. And if you look at the long-term endpoint, primary endpoint of non-fatal MI, non-fatal stroke, or mortality, you see here that whether their patient is in the group that got tight control or usual control 130/140 in the usual control, meaning historical usual control, there was no difference in the primary event rate. After greater than 140, the events go up dramatically. And actually, an extended follow-up of these patients, those with tight control, actually had a higher mortality than those with 130/140. And in fact, we never published this, but in the FREEDOM trial, the optimal blood pressure was 150. And I don't know how to say that because it's not politically correct, doesn't comport with the guidelines. But the fact remains that low blood pressure, getting the blood pressure too low, and some of our patients will come in and say, my blood pressure's 115, and doc, I'm not in control. This is wrong. So I think the message is we can't drive for hypotension. and we need to continue to evaluate this. So blood pressure, really, really important. Statins are the mainstay of therapy, and we know this. Based on whatever your LDL is, you benefit from statin therapy. This is the heart protection study. And we see here that with statins in green and placebo in red, the lower your LDL, the better off you are. So what does that mean in the current era? Well, we have newer drugs now called PCSK9 inhibitors. These are inhibitors of the receptor and prevent PCSK9 uptake. And you'll see here that in this trial called Fourier, initially was randomizing patients to a PCSK9 inhibitor or matching placebo. These are patients who have atherosclerotic vascular disease who are not yet at target even though they're on optimal statin therapy. So their LDL is greater than 70 and they're on a statin. So what do you do and how do you augment therapy? And in this trial, I'll just say that if evolocumab versus matching placebo, you'll see here how low the LDL can go. This is in millimolar. This is for David Taggart and our British friends and UK colleagues. Millimolar, you basically multiply by 40. So in a sense here, the baseline LDL here is about 100, and you'll see here that they drive it down to as low as 20 milligrams per deciliter in American units, or 0.5 millimolar in UK units. And you'll see here that this is what happened when the patients were randomized to evolocumab or placebo. What happened at the end of the trial, there was a 15% reduction in MACE events, no difference in mortality, and we'll talk about that. Mortality is a very difficult endpoint to interpret sometimes. And so the idea is if you don't follow people long enough, you don't have time to show a difference in mortality. This is where peri-procedural MI came in, by the way. This is why it came, because we didn't follow the patients long enough, it became a surrogate for mortality. My thinking is if you follow, this is a bit of an aside here, at 5 to 10 years, if you follow people long enough for mortality, those peri-procedural MIs that were consequential will manifest, as John pointed out. But what happened here in Fourier is at the end of the trial, they crossed everyone over. So the people in placebo got crossed over, and they still achieved the same LDL as the original group. So now you have two groups of patients. You have the groups of patients that were treated initially with evolocumab and those that were treated later with the evolocumab. Look at the results. This compares those two groups. This is at the landmark. This is after the main trial. What happened in the subsequent months and years? You'll see here there's a reduction in death of 23% in the group that had evolocumab up front versus those that had placebo up front. So there's a legacy effect to medical therapy. This is what we have to understand in coronary disease. We need to treat earlier, and we have a legacy effect with a mortality reduction that's equal to being on a statin or not in the main trials. So very, very important. PCSK9 and getting the LDL lower should be in everyone's mind, including the surgeons. And Joe's asked me to cook up that data where not cook it up, but bring it up. The data about bypass being even benefiting even more from medical therapy, something we want to write up when we have time in the next few months, I guess. The issue is now the newer anti-diabetes drugs. These drugs also may be effective in patients without diabetes. There are three classes of drugs. I'm going to start with the one that is DPP-4 inhibitor, which prevents the breakdown of GLP-1, which is semaglutide and liraglutide, these wonderful weight loss drugs now. The issue is DPP-4 therapies have been shown to be effective, but there's no difference in cardiovascular endpoint. They're safe, they're well tolerated. You want to get glycemic control, you can use a DPP-4 inhibitor like sitagliptin, saxagliptin, you'll hear the gliptins. But the idea is that these drugs don't change cardiovascular endpoints. The other two have been shown to change cardiovascular endpoints. SGLT2 inhibitors prevent the uptake. They actually are glucose-uric, so they promote glucose being spilt into the urine, which speaks counterintuitive to what we think about diabetes. And these drugs have been transformative. I'm going to show you the basic data. And the GLP-1 drugs are the injectable drugs, which also work by increasing insulin and reducing gastric emptying. That's how they work on obesity. And they've also been shown to affect cardiovascular endpoints. This was a monumental moment, September 17, 2015. So we're talking 8 years ago now, and patients aren't on these drugs. Even diabetes patients aren't on these drugs. And this was the empagliflozin study, EMPA-REG, which was conducted by my close colleague, Bernie Zinman, in Toronto when we were there. 7,000 patients with type 2 diabetes and cardiovascular disease. And it was the first trial to demonstrate mortality reduction with a diabetes agent. And you'll see here that there's a 38% reduction in mortality if you're on empagliflozin versus placebo, SGLT2 drug, and a concomitant, almost comparable reduction in heart failure hospitalization. Subsequent to this, trials have been done in heart failure alone and in heart failure with preserved LV function, which is a lot of diabetes patients that you're operating on, and there's reduction in events for these patients. So these drugs are the new statins. They're in the water. They should be in the water. All the trials are positive, and there are ongoing trials even in primary prevention that have been proposed. So the SGLT2 drugs, this is a monumental moment. 6 months later came the liraglutide studies of GLP-1 and the injectable drugs. And this is one of the trials. This is actually not the first trial that presented, but this is semaglutide, which is the drug that's in Ozempic, which is a GLP-1 drug and now used in weight loss at a higher dose. And you can see here something different. CV death, MI, and stroke reduced by 26% for semaglutide versus placebo. And you like to look at the curves, right? You see, whenever you see curves separating over time, that's an anti-atherosclerotic effect. And interesting enough, there was no effect on CV death, as we saw with PCSK9. Could be about the length of follow-up, but there were reductions in non-fatal MI and non-fatal stroke that contributed to the triple endpoint. So now all of a sudden we have two types of drugs. We have drugs that reduce the triple endpoint of CV death and stroke, MI, and you have the SGLT2s that save lives and reduce heart failure. But how many patients are on both drugs? You can just take a guess. It's well under 10%, even if diabetes patients are not on these drugs. And so we're moving forward now. Semaglutide used in obesity now, you're going to see this in your patients. They're going to be on semaglutide. They're going to be on SGLT2 if they can afford it all. And that's the real barrier, is cost. I did talk about the intensification, the endpoint of PCI, optimal medical therapy, driving this point home that in all the trials of PCI versus optimal medical therapy head-on, Courage, Berry 2D, and diabetes, Courage in all patients, no difference between optimal medical therapy and PCI, but when you adjust for the fact of where the LDL is a year out, you see that benefit in PCI that is dramatic. So the idea is intensification works, and it works for bypass too. Now, what about PCI? What should we do about PCI? Well, PCI, you can see here when it's two vessel disease, there's a lot of green lights here. Intermediate disease, findings on non-invasive testing in patients who are on anti-anginal drugs. You can see that we can still do PCI, and PCI should be done in patients with less extensive disease. We can't do bypass on everyone, particular single vessel disease. Now, the one caveat is the patient with proximal LAD disease. What do we do there? And we're doing PCI like crazy on these patients. I have some reservations about that, but that's something for another day. And Mark Ruel has proposed a trial called Liberty on the heels of freedom. That would be isolated LAD disease, minimally invasive bypass versus PCI. We just can't get the interventionalists to buy into this, and that's one of our challenges. So in conclusion, the patients with stable disease need optimal medical therapy. It is the cornerstone of therapy, and we need to be obsessive about this. And this is part of the heart team approach, including the clinical cardiologist in the heart team approach. And I still think there's a role for PCI in reducing symptoms, improving quality of life in the right patient, and that's what it takes into account, patient preference and physician decision-making. So I'll stop there. Thank you very much.
Thank you, Dr. Falcao, for the very informative presentation. So our next speaker is Dr. Mario Gardino. And Dr. Gardino is the professor of Weill Cornell Medical College. He's author of a number of research papers and the principal investigator of several important clinical trials, including the Roma and the Roma Women trial. The Professor Gardino will talk about the future of coronary surgery research.
Thank you. Thank you very much for the privilege of the podium. And yeah, my talk is to discuss the future of coronary surgery research. So I think every time you are asked to talk about the future, you should quote Yogi. I mean, I'm Italian, clearly, by origin, but being a member of Dr. Eison's team, I was educated on American baseball from the very first day, and I found a lot of inspiration for research in Yogi. But seriously, as a community, we must admit that we do not have a great reputation for the type of research that we do. It was in 1996 when Sir Richard Horton, the legendary editor of The Lancet, defined our research a comic opera. And this unflattering definition was not actually used for the first time by Sir Horton. It was 100 years ago that another legend of medical biostatistics, Dr. Greenwood, for the first time defined our clinical research as a comic opera. And the key point why both were defining what we do for research comic is because at that time, and unfortunately even today, we mostly rely on non-randomized study for comparative effectiveness evaluation. And this is wrong. It's wrong in every field of medicine. I would argue that it is even more wrong in surgery. The decision to make one operation or another, or the decision on which operation to perform on an individual patient, is a very complex and a very important decision. It's actually the key reason for our success clinically. The reason why we have good result as clinical surgeons is because we tailor our technique and our operation to the patient that is in front of us and we are eyeballing. But this is good clinically, and we are good at it, but it's very bad for research purpose because patients who receive different operation are different patients, and they should not be compared. Tom, I'm sorry, I enjoyed your presentation of non-randomized data showing that the patient who receives multiple arterial grafting lives longer. But that's why they received multiple arterial grafting, because the surgeon knew they were going to live longer. It's impossible to derive comparative effectiveness evaluation from those studies. And unfortunately, we keep doing that. This meta-analysis of all the study that over the course of 5 decades look at the outcome of patients that received the bilateral versus single internal thoracic artery for bypass surgery. Well, not surprisingly, the overwhelming majority of them showed that patients who received the bilateral internal thoracic artery lived longer. But then when we looked only at the propensity-matched study, so arguably the best level of non-randomized evidence that one can get, we found that the same survival difference that was seen at the end of the follow-up was seen at 1 year, a timing point where we know there is no difference in patency rate between artery and vein. So this is a perfect example of treatment allocation bias. We, as a surgeon, reserve the treatment that we believe last longer, in this case, multiple arterial grafting, to those patients that we believe will live longer. We are pretty good at that. But again, this type of treatment allocation bias is just impossible to match using statistical technique. So are we not doing enough randomized trial? Yeah, we are not. This is an interesting analysis that one of my fellows did a few years ago, looking at the evidence base for the 10 most commonly performed surgical procedure in the United States. This is not cardiac surgery, this is general surgery. This is all surgery. And so in red, you have the totality of the evidence, and the sad blue line is the percentage of randomized trial. It is in the single digit, and it has not improved over the course of the last 3 decades. Okay, but you know, you're a cardiac surgeon. We do better than that. Not really. This is cardiac surgery. The red line is the percentage of randomized trial. It's even more sad. It's going down in the last 2 decades. So yes, we are not doing enough randomized trial. And why is that? Well, there is no doubt that the randomized trial in surgery are different, and I would argue more complicated than the randomized trial in non-surgical specialty. There are a number of different, we don't have the time to go over all of them, but the surgeon component and the technical component of the operation add a layer of complexity to the already complex scenario of randomized trial. 20 years ago, a survey was performed among surgeons and surgical trialists, asking them why we cannot test most of the key research questions of our practice in randomized trial. And essentially, there were 3 key answers. The lack of equipoise from the surgeon, both as a community and individually, the lack of patient willingness to undergo randomization for something that is so important as a surgical operation, and then surgeon preference, which is an elegant way to say surgeon confidence with the operation being tested. And Sir Orton very appropriately reminds us that those personality traits that probably are the key to success as clinical surgeon are not necessarily good for collaborative clinical research. Some of us are so invested in a technique or in a particular theory, we have dedicated all our life a career to it, that we are not comfortable testing it in a randomized trial where this intervention or this strategy may very well lose. Another challenge with surgical trial is the timing. In surgical intervention, they are not fully mature when they are first presented by few innovators, so you cannot test an intervention too early in the natural history of its introduction. But if you wait too much, the window of opportunity of equipoise can simply close because the community just adopted that intervention, and at that moment, a comparative effectiveness trial, it's impossible. A perfect example of that in general surgery is laparoscopic surgery. Laparoscopic surgery was introduced and then adopted very rapidly by the community before being tested in formal randomized trial because surgeon thought it was great, patient thought it was great. So timing of surgical trial is much more, timing a surgical trial is much more complex than timing a non-surgical trial. Well, the surgeon effect, I was alluding to that. We know there is a volume to outcome effect. That was the seminal NIJM paper 20 years ago showing a clear association between volume and outcome for complex surgical procedure, including cardiac surgery procedure. In general, in surgical trial, the crossover from experimental to control is considered a good surrogate of the comfort of the surgeon with the two intervention being tested. And remember, in surgical trial, the experimental intervention is by definition the more complex intervention because this is how surgery evolved. We go from simple to complex. So in the ART trial, the percentage of crossovers from bilateral to single internal thoracic artery varied on an individual surgeon basis from 0% to 100%, so showing huge heterogeneity in comfort with the operation being tested. And we have shown that in cardiac surgery trial, when the crossover from experimental to intervention is above 7%, the trial will be neutral. There will be no difference. This is related to the deliverability of the operation. There are strategies to overcome the surgeon effect. There are a number of strategies to optimize the deliverability of the intervention. I have listed some on those slides, but we are not using them. This is a review of all the surgical trials published from 2011 to 2020, and you see that 80% of the trial did not control for the quality of the intervention. In 95% of the cases, there was no monitoring of the delivery of the intervention at all. And even more concerningly, 60% of the trial did not even provide the detailed description of the intervention in their protocol. So if you don't even describe how the intervention should be done, you cannot expect homogeneity. There are challenges in enrollment in surgical trial. We have looked at the surgical trial published over the course of a decade, and we have found that 20% of them did not achieve the target sample size, and some of them missed the sample size by a quarter or by 50%. And when we do reach the sample size, we struggle enrolling minority patients and women. Achieving funding for surgical trial is complex. It's not impossible, but it is complex. This is NIH support for research overall. On the left of the slide, you see a progressive increase with the time, but then when you stratify by medicine versus surgery is in the bottom quadrant. You see that NIH funding for surgical research is actually going down, not up. We do not know if this is because we are not applying enough as a surgeon, or we are applying but not being successful. Industry is generally not very interested in funding surgical trials. This is a comparison of industry participation to surgical trial for interventional cardiology and surgery. In interventional cardiology, over 60% of the trial are funded by industry. Totally different story with surgery. And we desperately need randomized trial. What I did in this slide, I went over the program of this meeting. Those are the topics that we will be discussing in the next 2 days. Those topics represent what we do every day. This is our practice. They have never been tested, or they have only partially been tested in a randomized trial. We as a community desperately need randomized trial, but we are not doing them. Now, 2 minutes on AI. Very hot topic, just a quick PubMed search, and will tell you that this is really the next big thing in everything, but also in clinical research. The general thought, which I think is wrong, is that the application of AI will improve the performance of our statistical model. There has been some work on that, and I don't think this is true. There is a small improvement in performance or in accuracy of model compared to traditional technique, but the price that you pay is huge. You lose complete control of the details. You do not know anything about the process. You cannot troubleshoot your model. It's a black box. You have an input and an output, and you don't know anything of what happened in the middle. This is very different than what you have with traditional statistical approaches, and the benefit is really, really small and not clinically meaningful. AI, however, is great in other application, and I think the most exciting application is the detection of complex cluster, multimodal cluster. This is in critical care medicine, where you can clearly see how AI-based algorithm can detect clinical deterioration much earlier than physician-based algorithm. Or in the operating room, our anesthesia colleague have shown how AI-based algorithm can assure much better and tighter control, you see in red, of intraoperative systemic pressure compared to physician-driven algorithm. And then there are some, I would say, creative approach of AI, We have been playing a little bit with ChatGPT in the last few weeks, and we have found something interesting that I want to share with you. First of all, we have used ChatGPT for what, to me, is the most challenging part of research, getting your idea. We asked ChatGPT what are the 10 research topics in coronary surgery that were published on High Impact Factor Journal. And then we refine our search and say, okay, of those 10 topics, how many have the least available evidence? So which one would be more likely to be published in High Impact Factor Journal? I look at those topics, they're really good. So, I mean, that to me is the most challenging part of research. Also, news flash, ChatGPT is it's great for graphics. We have used it very successful for logo for our trial. This is for the Prince trial, the precardiotomy trial. This was generated in 2.5 seconds. I mean, I was going to the Medical Illustrator and paying a ton of money. This is 2.5 seconds and it's totally free and you have all the options you want. I think we want to add the crown because it's called Prince. You can do everything. And then we don't use it for language and translator, but I can see how this is very valuable for non-native English speakers, especially from those countries where the alphabet and the grammar is totally different. So those are just few silly applications that, however, can be, I think, interesting for those who do research. So my conclusion, I strongly believe that as a community is the time that we stop wasting time and resources in non-randomized comparative study. There is an urgent need for randomized trial to test several key questions of our profession. And then for AI, I think it holds great promise, but not for analysis as generally taught. Thank you for your attention.
Well, thank you very much, Mario, for that outstanding review of where we need to go in research. I'd like to invite now Gianluca Torregrossa to come give his talk on coronary surgery innovations. And Gianluca is coming from Lankino Heart Institute in Philadelphia and is a member of the ESCAS board. Gianluca.
Thank you, everyone. Thank you. So nice to be here. It's the annual appointment that I'm looking forward to, and it's nice to know that the room is full of people that believe and really commit themselves towards the care of patients with coronary artery disease. I want to spend a couple of more seconds about my conflict of interest. I will speak in the next few minutes about a lot of products, a lot of companies, and I want that the conflict of interest is very well declared. If you have followed me or if you have seen one of my presentations before, I've used these slides several times. This is the slides of a story that I found it striking and extremely important for all of us heart surgeons. It's the story of this man, Stefan Ilop, the last CEO of a company named Nokia. You remember Nokia? We have all had one. And Nokia was the 5th most valuable brand in the world, a multi-billion company that in less than 5 years declared bankruptcy and completely closed and became basically a surrogate or a branch of Microsoft. And it's very interesting how in the last speech that Stefan Ilop gave, these words were the most accurate understanding of what happened to Nokia. He said, we didn't do anything wrong, but somehow we lost. And it's true, they didn't do anything wrong, but they didn't innovate enough. They were not ahead of their competitor. And guess what? Look in your pocket. What type of phone are you in this moment handling? It's not a Nokia. It's something else. If you do not innovate, you will be completely eliminated from the competition. And I believe that the story of Nokia and cardiac surgery, not only coronary, but in general cardiac surgery, has a lot to teach to all of us. We do a great job. We care a lot about our patients. We see that the results of what we do is fantastic. But guys, we need to change the game. We need to innovate. We need to keep moving forward and moving higher the bar. If we don't do it, we will be eliminated from the competition. And now I can challenge you and I tell you, so what is the most important innovation in coronary surgery for the last 10 years? There's pretty silence in the room here. Huh? We are still talking about radial artery and Rita and vein and arterial, off pump and on pump. This is like in 1990s, they were talking about the same topics. So somehow we need to change the game. On one way, saying that we are performing the same surgery of 20 years ago, it's wrong. We are not performing the same surgery. And when you look at these slides, you can tell that. These are the results of FAME-3 trial. And FAME-3 was designed at the end to prove superiority of FFR-guided PCI respect of CABG. And this comes from a beautiful presentation available online, I think on YouTube, by William Ferron, the first author of FAME-3. And he said it. We took the benchmark of CABG as syntax. And look, if our outcomes were exactly the same of syntax in 2023, FAME-3 would have proved superiority at 1 year of PCI FFR guided. But it was very surprising, even for the steering committee of FAME-3, CABG did so much better. It's true that silently we are getting better. The iteration is the key of innovation. We are keep doing, and we do this meeting and more meeting, and we keep talking and refining the techniques, and thanks to that, our outcomes are much better. Usain Bolt didn't do his world record on the first attempt, and he even didn't do when he was very young. He did it a little bit later in life. You keep repeating yourself, and you achieve the world record in the 100 meters. You become Usain Bolt. And I think that meetings like this, keep talking, multi-arterial, off-pump, understanding of stroke risk, is what makes the surgery way, way safer respect of 10 years ago, 20 years ago. But on the other side, innovation is necessary, and innovation doesn't start from outside. Yes, industry can help, but start from us, from the ability of adopt the technologies that are available to us. If we don't do that, we are gonna end up with an iPhone or a PCI in our pocket. So what are the innovations that in the last 2 years have really attracted my attention? And there are out there. So the first one has been the use of the Impella. Impella 5.5 in the use of CABG. We will dedicate an entire session tomorrow about heart failure in coronary bypass grafting. And the concept of using a device to sustain cardiac output perioperative before and after surgery, immediately after very complex low ejection fraction surgery is attracting. Can we serve patient population that potentially up to now would have been excluded to receive CABG? Patients with cardiogenic shock, patients that I call discrepancy between the angiography and ischemic cardiomyopathy, the guy that has probably only 2 targets, an LED and a very terrible PDA, and yet he comes to you and has a 10% ejection fraction, and the guy is not transplant on candidate. So we should think and we should be aware of this technology and be part of it. Going into the distal anastomosis, CORNOT and microCORNOT is something that I've been personally adopted in the last 2 years with excellent outcomes and results. We will present our data of our team and our group, but microCORNOT is becoming a device available not only for the stitches that we use in valve size, but also for 6.0, 7.0, and 8.0. Now, I'm pretty sure that I can read the mind of all of you right now and say, oh, why I do need, I know how to tie a knot. Do I really need something to tie down a 6.0 or a 7.0? And if you think when CORNOT came originally into the market, was exactly appreciated or welcome in that way from the surgical community. Everybody was saying, well, do I really need it? Why we have this device? Are we training surgeons and the next generation will not be able to make a knot? All things that keep repeating. But reality is that when you look at, and this is one of the angiographic data of the CORNOT, when you look at the adoption of CORNOT in valve surgery, there is a huge amount of valves that now have been implanted with Carnot. And we have all been there. When you have that aortic root that is small and you're trying to place a bigger valve, you know that putting down your finger is going to disrupt that aorta. We have been there, done that. When you see the delamination of the aorta because you are trying to push hard those nuts inside. So it's important for us to adopt a technology in coronaries for distal anastomosis that is available. Play with these instruments. Can we think about the potential of doing a complete TCAB or a complete minimal invasive procedure with this device? So again, adoption comes from us as a surgical community of this technology. Another interesting concept that has been presented on the EX this year was this device that is now currently in one of the first phase of testing here in the United States, and is a laser-based distal anastomosis connector. I've never personally used it. The concept was presented. There was a lot of comments during EX. The introduction of this laser to perform basically side-to-side anastomosis. That's the concept. The area of opening seems small, and there's some literature that are talking about the risk of having a too narrow or too small anastomosis. But again, it's on us. The outcomes in Europe has been very good. They're coming in Europe, they're here in the United States, and they're looking forward to have more support from the surgical community for potentially a device that can have greater impact, particularly in the minimal invasive field. Another important element has been proximal anastomosis. And among the proximal anastomosis, one of the new device is Viola. Now, proximal anastomosis is what I call the stepchild of coronary bypass grafting. I think is another big theme in which we all as a surgeon have not dedicated enough attention. We are all about the concept of distal anastomosis, 7-0, 8-0, radial, vein, multi-arterial, BIMA, but reality is that you play your risk of stroke when you touch your aorta. And that's true both for on pump and off pump. Very few surgeons are trained in using one of the anastomosis devices that are available in commerce. And I think we need more, and Viola is the latest one, to try to minimize risk for proximal anastomosis. That's true if you do off pump as well as if you do on pump. If you're doing an on pump, sometimes if you're doing a very long run of bypass of cross clamp, you might decide to release your cross clamp, avoid a side beating clamp that is the worst things you can do to your aorta, and instead use one of these devices to really minimize the risk of stroke, and in the meantime reperfuse your heart. The concept of Viola here is to basically create a bloodless field where the surgeon can comfortably perform his proximal anastomosis with one or two multiple vein or arteries, and it's reusable for different sites inside of the aorta, in the aorta. In the world of atrial fibrillation, we have two devices that are interesting. One is the Encompass clamp, and this one has been definitely increasing the number of patients that receive treatment for atrial fibrillation, allow you to do a treatment of a posterior box complete with your heart without opening your left atrium. And considering how many patients have atrial fibrillation and are not treated and go into the operating room, this is a device that we should become familiar. This is good, for example, if you're doing a very complex low ejection fraction patient who has atrial fibrillation, you can avoid to cross clamp and then do it on beating heart. Or you can really reduce your cross-clamp time. You can do it for CABG in the CABG sphere. And look this number. Since his introduction, over 7,000 in 2023 has been adopted, and 45% were used by surgeons that have not done before a treatment of atrial fibrillation. In the world of atrial fibrillation, again, a new device, and we will talk even tomorrow in the atrial fibrillation session, comes from Medtronic. There is a new clip available in commerce, and it's now commercially available to exclude left atrial appendage. This is one of my OR. I had the pleasure to implant the fifth in the world case during a beta. You see that there is a RITA that passes through the transverse sinus, and the device with low profile comes and gets it into the field. This is how it looks. I try to move forward. In the world of robotics, and this is my last few slides, very first SSI mantra from Srivastava, cardiothoracic surgeon always involved in robotics, has been presented at EX this year. They have already done TCAB with this device. They are coming to United States for being placed in laboratories only for now, but with the idea of going into surgery soon. The concept is that they will bring also a distal anastomotic connector that will be implemented together with the device itself. And these one are some of the techniques and some of the technology that will be available. You see, this one is one of the TCAB done. The other system that will be available, not for cardiac surgery immediately, and not in the US at the current time, is Hugo by Medtronic. The great news is Medtronic has always been a very driven cardiothoracic surgical company. Hopefully, we can take the next step into the concept of robotic coronary bypass grafting, one of the main concepts, one of the themes that I personally dedicate my profession for. Finally, and I want to be very brief, I believe that the most important revolution in cardiac surgery in the next few years will be in the way in which we treat our patients post-op. We need to put more attention. As you can hear out there, quality of life is becoming a major point. You like it or not, is the new weapon that cardiologists are throwing into the concept and mix of PCI versus CABG trials. Quality of life depends also on us. How long do you keep your chest tube? Why, if you get nowadays an ACL repair, you go to cardiac rehab the second day after surgery, while instead we send our patients to rehab days and weeks after? Why we don't implement medical therapy? What is pain and how we manage? Why we don't allow patients to drive for 4 weeks after a sternotomy? Can we rigid sternal plate fixate and everybody and start to let them drive earlier? These are the elements that change the way in which patients perceive quality of life after surgery. Finally, I recently had the pleasure to try this device. Is a device that allows you to calculate very precisely cardiac output, blood pressure, heart rate in every patient on a fingertip. And this is basically, you do not need a Swan-Ganz anymore. And again, this is the post-op care. This is the big revolution that we all need to be aware of, caring for our patients and the quality of life. I finish with another story. I believe that story somehow has always the power to bring us to a special moment in which our mother was reading us a story and tell us once upon a time. And this is the story of this man who is bringing his son during the early 70s to Norway for a camping. He's a scientist, he's a biologist, a chemistry, and he see a mushroom during this camp that he have never seen before. He bring him back in Switzerland, and out of this mushroom, he make cyclosporine. Cyclosporine was really the medication that changed completely the outcomes of an operation that was described 20 years before. In robotic coronary bypass grafting, we are waiting for our Norwegian mushrooms. We are waiting for that element, that enzyme that is going to activate the reaction and making affordable and making possible for everybody, for every surgeon to learn it, for a large majority of patients who currently receive multivessel PCI to be treated with 1 or 2 mammary robotically done. I want to thank you so much, and it was a pleasure to be here and see all the new friends. Thank you for this great opportunity.
Thank you, John. Thank you, Gianluca, for that very exciting and innovative talk. And now we will welcome Dr. Steve Freems from Toronto to talk about the relevance of the ischemia trial.
Hi, thanks very much. This talk is going to be quite a bit different than the previous talk, but hopefully it'll sync with what Mike Farku said in his statements. So it's great to be in New York and great to be at ICC. I'm Stephen Freems from the University of Toronto. These are my disclosures. I am an ischemia author since Bruce Ferguson withdrew. So the surgical societies withdrew their support for the 2021 American Revasc guidelines. The primary reason was the change in the recommendation for patients with triple vessel disease, preserved EF, and stable ischemic symptoms, and we know what happened. So all discussion within the guidelines committee is confidential. However, in the text, we say, quote, after several hours of discussion, to convey that the new class recommendation was not reached very easily. The reasons for the change are listed here. Now, some of the alternative explanations are presented here. Now, importantly, ischemia is an excellent trial of an invasive versus a conservative strategy. It is useful for the community cardiologist. However, it is not necessarily a comparison of OMT and CABG, OMT and PCI, nor CABG versus PCI. PCI and CABG are as treated subgroups, and survival comparisons were underpowered. We'll review some key aspects of the ischemia trial. This is a schematic of the study design. Patients are randomized to either invasive strategy or a conservative strategy. Now, by design, these patients were without left main disease. The primary outcome was a composite which included CV death. All-cause mortality was a secondary endpoint. In terms of the primary outcome, there was harm early in the invasive arm in red, but benefit late, but no significant difference overall between the invasive and conservative arms. In terms of mortality alone, there was no difference in all-cause mortality between the conservative and invasive arms. CV mortality was higher in the invasive arm early and lower late, suggesting that with longer-term follow-up, there would be a benefit seen with the invasive arm. However, there was increased non-CV mortality in the invasive arm, which begs the question, if non-CV death is unassociated with the intervention, what accounts for this difference? There has now been extended follow-up. Overall, all-cause mortality continues to be similar in the two strategies. However, CV death now does show a benefit with the invasive strategy, which unfortunately is offset by a continued increase in non-CV death in the invasive arm. There were no important treatment interactions. Even in the subgroup of patients with multivessel disease and 70% stenosis, there was no benefit in terms of all-cause mortality. We did see a benefit in terms of CV death, but harm in terms of non-CV death. Now, in ischemia, the modality of revascularization was not randomized. Per protocol, PCI was recommended for low syntax patients, CABG for high syntax patients, and either for intermediate syntax score patients. PCI was the dominant form of revascularization compared to CABG. In the invasive arm, about 20% in the invasive group did not get revascularization, 2/3 because they had insignificant angiographic disease despite disease present on the CT scan, and 1/3 because of severe atherosclerosis unsuitable for any revascularization. Now, we talked earlier about definitions of procedural MI. For this, the SCI definition was used. So for some patients, definitions was biomarkers plus other clinical features, but there was a standalone definition, biomarker alone. Now, these slides were presented at the AHI, Bjorn Redford's, and he shared them with me, and the manuscript is now available in JACC. So these are the unadjusted outcomes for the primary outcome for the different groups. CABG is in green, PCI in yellow, conservative patients in blue, and the medically treated invasive patients in brown. So clearly, CABG had the worst outcomes overall. These are the 30-day and post-30-day adjusted hazard ratios for CABG and PCI patients compared to the conservative patients. And these are adjusted. So the early risks are higher and later risks lower for both CABG and PCI compared to the conservative patients. Now remember, these are observational results within a randomized trial. The patients were not allocated to CABG or PCI. The treatment physicians decided if they should get CABG or PCI. Now, spontaneous MI was highest in the control groups in blue. Interestingly, it was similar in the CABG and PCI patients, suggesting that using their treatment algorithm, they were able to achieve similar rates of spontaneous MI in the CABG and PCI patients. So this slide shows the individual events that contribute to the primary outcome in the 4 treatment groups. So the biggest event that contributed to the outcomes in the CABG patients were peri-procedural MI in blue. That's the bottom right lower quadrant. And of these, most were actually standalone MIs. This was reported in a previous publication in Circulation. And we know that the relevance of biomarker alone MIs, according to the SCI definitions, is unclear. On the other hand, in all the other groups, spontaneous MI was the most important event. So I'll now share some slides from Walter Gomez regarding the potential explanations for the ischemic findings. In an earlier study-level meta-analysis of PCI CABG trials by Mario Cadino et al., there was a survival advantage overall with CABG, but this was present for both CV and non-CV mortality. Now in Excel, a big contributor to the difference in all-cause mortality was non-CV death, and therefore considered potentially related to chance rather than related to the choice of modality. The non-CV deaths were mainly cancer or infection related. Now a difference in FAME3 was apparent also for non-CV death, and even in revived BCIS, which compared PCI and OMT, there was a difference in non-CV death. There is speculation that an increase in non-CV death due to greater cancer or infection is biologically plausible with second-generation DES. I would counter that there's alternative explanations. First of all, patients with chronic and acute CAD have systemic inflammation. Also, CABG patients have more complete and durable revascularization than PCI, and they could maybe tolerate cancer therapy or serious infections. And patients with CAD who are revascularized may be more likely to die from non-CV deaths than CV causes, so this could be a competing risk problem. In ischemia, we did see a marked difference in survival based on the anatomic extent of disease in a later publication. Conversely, there were many patients with prognostically less important disease, which may be the reason we didn't see a big difference between the two strategies. So to conclude, I think ischemia provides very useful information for the community cardiologist. The majority of patients who fulfill the inclusion and exclusion criteria do not have prognostically important CAD. To date, there's no overall survival advantage for the invasive strategy due to the risks of the procedure and offsetting CV and non-CV deaths. However, for the subgroup with the highest anatomic risk, there may be a survival advantage over the longer term. However, the comparisons are more inferential rather than direct, and the study will be underpowered to detect mortality differences. So ischemia cannot directly compare OMT and PCI. It can't compare OMT with CABG, nor can it compare PCI with CABG. These are all observational comparisons. In the CABG patients, the largest risk in these people with peri-op MI, this was largely from standalone biomarker definitions. I would say the reasons for the differences in non-CV death between the conservative and invasive arms are still unclear, but that longer-term results are pending. Thanks.
Well, thank you, Doctor. The last speaker of this session is Dr. Patrick Myers, and Dr. Myers is the Secretary General of the European Association for Cardiothoracic Surgery, the President of the CTSNet, and an International Director of STS. He's a cardiac surgeon at the Lausanne University Hospital of Switzerland. Dr. Myers will bring us a talk about US and European guidelines.
Well, thank you very much for the introduction, and thank you for the opportunity to talk about guidelines. Well, quite a controversial subject. So I don't have any financial disclosures, but of course I'm a surgeon, so I'm going to say that surgery is best and we should be promoting it in our guidelines. Now just coming back to the basics, of course the goal of CABG is to prolong survival and to decrease cardiovascular events. And just to do an overview of our current guidelines, the European guidelines are quite old, they're 2018. We've been talking with ESC to try and update them. They're currently working on chronic coronary syndrome guidelines, which should be published next year. I must say that that's somewhat complicated working on it. But let's go over what our current recommendations are in Europe. And as was mentioned in previous talks, essentially as soon as we have proximal LAD disease, we have a class 1 recommendation for CABG. And PCI, depending on the complexity of disease, and the lower complexity also, in some instances, has a class 1 indication. Now, of course, this is what we discuss in our heart teams and with our colleagues in interventional, non-interventional cardiology, is that there are clinical characteristics and anatomical and technical aspects that favors either PCI or CABG that you well know. Now, the latest North American guidelines, going back to the 2021 coronary artery revascularization guidelines that Jennifer co-chaired, as well as the latest 2023 chronic coronary syndrome guidelines, were somewhat controversial. And the main controversy, as was alluded to by Steve just previously, was that there was a downgrade of CABG in patients with multivessel disease to a 2A when they have a reduced ejection fraction and a 2B with a normal ejection fraction. Now, going into the text, the main reasons for this is that the studies that support CABG in these patient populations are relatively old, and it's written in their text that newer evidence from the ischemia trial was used to downgrade the recommendations from CABG. Now, they do also state that the ability of PCI to improve survival compared with medical therapy alone in patients with multivessel coronary artery disease remains uncertain. Well, the text always gives us a lot more details. The issue is that the treatment algorithm that's provided, if you look at that, looking at patients with multivessel disease, normal ejection fraction, we have a 2B recommendation for CABG and for PCI. And as most physicians just look at these treatment algorithms and what the level or the recommendation class is, well, it would appear that they're at the same level. When one of these treatment options has not actually shown any improvement in survival. So to summarize the major differences, even if our European guidelines are somewhat older, revascularization is recommended over optimal medical therapy and CABG over PCI, particularly in patients with intermediate or complex coronary artery disease and diabetes. The North American recommendations seem to put revascularization on an equal footing to medical therapy. In many indications, CABG is considered equal to PCI, but of course still considered superior to PCI or recommended in complex coronary artery disease and diabetes. Now these North American guidelines, as Steve alluded to, had a pushback from the surgical societies here in the US, but also around the world. And I think this illustration is quite interesting from Faisal Bakin, looking at the studies that were used to support this downgrade in recommendations. And if we look at the individual studies, we see that they either supported a survival advantage for CABG or were not designed to tease that out. And so it's actually somewhat difficult to understand how CABG was downgraded if the supporting evidence actually supports CABG. Now, one of the elements that was mentioned in the North American guidelines was the fact that the evidence supporting CABG in these patient populations is somewhat old. Of course, we go back to the Yusuf meta-analysis, Lancet 1994, that showed that there was a survival advantage of CABG compared to optimal medical therapy. Since then, as Michael Farku showed us, medical therapy has improved by leaps and bounds. But what about CABG? Well, from the studies in this meta-analysis, there was only 10% of the patients who received a LIMA to LAD. I mean, that's not even within our quality metrics anymore. There's no multi-arterial grafting. Only 25% of patients received aspirin. 20% were on beta blockers. There were no statins. So the medical therapy was really poor. And we've also made outstanding progress, even if we're not yet at the goals that Gianluca pointed to in the future. We have made quite a bit of progress in perioperative care, myocardial protection, and so CABG has improved quite a bit. So I think just putting out the previous evidence based on the fact that it's gone beyond its sell-by date, I think is somewhat controversial. Now, if we look at CABG versus OMT with modern evidence, this meta-analysis by Mario and colleagues, using only RCTs with what we would consider modern, not quite as modern as Dr. Farkur's new medical therapies, but patients here at least had aspirin, beta blockers, and statins, and we see that at 5 and 10 years, there's still a survival advantage of CABG over optimal medical therapy. And maybe one message also is that there's no RCT that's shown a survival advantage of PCI over optimal medical therapy. We know that from the COURAGE trial going back to 2015, but also more recently the REVIVE BCIS in patients with multivessel disease and LV dysfunction. There was no advantage of PCI in these patients. So this is a very controversial slide. This is a bit tongue-in-cheek, but you can wonder if there's really an indication for PCI in chronic coronary syndrome, because there's no trial that's shown a survival advantage of PCI over optimal medical therapy. As we saw in the ischemia data, PCI is associated with the periprocedural hazard, which we can't eliminate completely. And so that risk compared to medical therapy is always there at the onset of treatment. Unblinded trials such as COURAGE suggested that essentially PCI is giving us a symptomatic benefit only, and sham control trials, the Orbita and more recently the Orbita 2, showed that compared to optimal medical therapy, there is no symptomatic benefit. You have to take off all the anti-anginals and create more symptoms to be able to show that there is a symptomatic benefit. So you really have to wonder, is there a room for PCI in chronic coronary syndrome? Of course, in ACS, that's a very, very different story. Now, going forward, it seems like a lot of the research now is to show that there's non-inferiority of PCI to CABG, since we have difficulty proving that it's better than OMT. And is it really non-inferior to CABG? Well, I think there's extensive data that shows that that's not the case in definite patient populations. We see that from the Stuart Head meta-analysis from the Lancet in 2018, that there's a clear survival benefit of CABG compared to PCI. And in more recent data from the Syntax extended survival, again, we see a benefit for CABG over PCI. The FAME3 trial, now here it's a little bit of a Jedi mind trick. This was designed for non-inferiority, and despite changing that non-inferiority margin while recruiting patients, they did not meet that primary endpoint of non-inferiority. So it's not non-inferior. Formally, you can't say that CABG is superior, but I do think that that should be the message. And that's just at 1 year, when we know that the benefit of CABG is much longer term. Now, if we look at their 3-year results, on the left side of the slide, we have their pre-defined secondary outcome measure at 3 years, which was death, MI, stroke. They removed the repeat revascularization from that endpoint. And at that point, we have a hazard ratio of 1.3, but a p-value that is of 0.07, so non-significant. And the conclusions of this paper, which I think editors should have a role in making sure that conclusions such as these do not get published, is that there's no difference. There's a difference. It's just not statistically significant because they weren't designed to power their study for that difference. If we do the same analysis doing the initial primary outcome measure, which includes the repeat revascularization, even if I know that that's a controversial outcome measure, we see that there the p-value is highly significant with a hazard ratio which is at 1.5, which is the same as it was at 1 year, which was their primary outcome measure. So this slide from Bill Bowden, I think, is he's always very, very adamant on this element, is that there seems to be a concerted effort to conflate the benefits of CABG with PCI with questionable systematic reviews, meta-analyses of old trials that group together lots of different patient populations. Now, Steve gave us a wonderful overview of the ischemia trial and how it doesn't really apply to CABG patients. Of course, it's a negative trial for their primary outcome measure, but it wasn't designed to determine if CABG improves survival. Only 26% of the patients in the revascularization or among revascularizations were CABG, and even among the initial invasive group, more patients received optimal medical therapy than CABG initially. Any comparison between CABG, PCI, OMT is non-randomized, so it's an as-treated. It's based on a heart team decision, and so should be considered no better than any observational data. If we look at the patients who were in the invasive group, 71% had multivessel disease, 41% had diabetes. These are CABG patients, if we believe that. So CABG was vastly underused because only 20% of these patients received CABG. And we don't have any good data on disease complexity in the initial conservative group because these patients only underwent CTA and not angiography until they developed a clinical event. So we have a lot of lacking data in terms of complexity, and we can't have a comparison group between CABG and other treatment modalities. And also looking at the complexity of disease, we see here the Duke 6 and Duke 7, which are the traditional CABG patients. If we look at that, there would just be 43 patients in this group, and that's quite surprising to have such a low number of patients with high complexity disease. So again, an illustration from Faisal Bakin of saying that using the ischemia trial to try and influence the CABG recommendations is somewhat misguided. To end this on a more positive note, and I'm sorry, I'm over time. As a moderator, this is totally unacceptable, but let's have a little bit more positive. We had a recent left main review. As you know, when the EACTS removed their support for the recommendations from our 2018 left main chapter. And here we had an outstanding group of 6 interventional cardiologists, or 6 cardiologists, 6 surgeons, who came together. And with this, with a very good memorandum of understanding of how to work on this, they came to some really excellent recommendations, I believe, just showing what the outcomes were. And in the end, this is the first time, I believe, in the history of interventional cardiology that there was a downgrade from a Class 1 to Class 2A recommendation for PCI in the low to intermediate syntax score. Now, this unfortunately is just a review of the previous guidelines and can be used as a recommendation for upcoming guidelines, but I believe our colleagues from EAPCI are not quite of that view. And so we will see what the outcome of our next CCS guidelines are. The other positive element is we had last year, there was this meta-analysis by Mario that garnered quite a lot of comments on Twitter and so on showing a huge benefit of radial artery as a second graft, looking at different randomized trials data. And this was somewhat surprising to have such a huge treatment effect. And following the request from the editor of our journal, we were provided the data from all these different trials, or the data that was used for this meta-analysis, and we're able to independently redo the same analysis, do the propensity score matching in a different way, which, as you see on the lower part of this slide, the treatment effect was in the same direction, but was not as pronounced. It's not saying that one approach is good, one approach is bad. They're both different ways. There are many ways to analyze data, and there's no best way or good way to do it. But I think that having the data provided openly to be looked at and analyzed separately is a very positive development in that we have questions about the results and analysis. Well, we can look at the data and have that result a little bit better informed. So I think that this is a very positive development, and I hope we can go in that direction in the future. Just as the FDA requires that all data, the raw data, be sent to the FDA and reviewed by the FDA, perhaps our guideline committees should be working in that direction. Also of note is that we have separate documents on how to develop guidelines in North America and Europe, and we're currently working together between our 3 American associations, including the ESTS for thoracic surgery, to have joint guidelines, documents, and a joint way of how to develop these guidelines. Thank you very much for the attention.
Thank you very much. That was an excellent session with very interesting topics. I think we have about 5 minutes for discussion. Are there questions from the audience?
Is it on? Good morning. Timo Nazari from Berlin Charité. Thank you for these great talks. This is basically a question for the entire panel. When we're looking into the future, I mean, we've talked a lot about mortality and cardiovascular events as a primary outcome of all these trials. But if we want to compare optimal medical therapy, PCI, and CABG, might it be beneficial to also look at some other outcomes, patient-reported outcomes, such as exercise capacity, symptom relief, and quality of life? Because I think if in the end, with the heterogeneity of the data that we have, it shows that there is no survival benefit. I think these patient-related outcomes are actually important when we look at the guidelines and actually look at how we're going to consult our patients later on in deciding which therapy branch they're going to take. I think mortality might not actually be the important outcome, but actually patient experience, patient-reported outcomes, I think, more important looking forward, and I think we can truly benefit from that looking forward.
Thank you for the question.
Thank you if I can make a comment. Yeah. I would advise this audience not to be persuaded by patient-related outcomes. This is a cardiology attempt to try and disadvantage the survival benefit of CABG by mixing it up with other things. For most patients undergoing CABG, we're doing something which will give them a 20-year outcome. So to say that at 6 months they had a sore chest or whatever, it's irrelevant. And it's really being done because, I believe, it's an attempt to try and denounce the advantage that CABG has for most patients. So I'm not talking about an old, frail, elderly patient. I'm talking about someone in their early 60s with a 20-year life expectancy. To say, well, at 6 months they had a sore chest, therefore we won't do CABG anymore, this is completely dishonest medicine. So I would persuade or try and persuade the audience not to be misled by these attempts to downgrade the very significant survival benefit of CABG for most patients. Thank you.
I think you raise an excellent question, and that's one of the reasons why the American Heart Association has patients on the guideline writing committee, because decisions are made with the cardiologist and the surgeon and the patient at the bedside, and you have to include patient preferences, family preferences. We've all done a CABG on the patient who won't take dual antiplatelet therapy. We've all sent people for PCI who are the single breadwinner of the family, and they have no money, and the person has to go back to work, or they have to do something the next week. So there are so many other factors that are involved, and I think you raised an excellent question.
Yeah, I would just add that I don't think we should be so bold to think that we know what's best for patients. We should, and I agree. I happen to agree with David. I think that it's how we educate the patient. You can say you can be alive and well 20 years from now, or you have a sore chest at 6 months. You know, in the middle of the sore chest, you might think, geez, I'd rather have gone for the less invasive procedure.
Go robotic.
I think it's all about how we educate the patient, but we need the patients at the table with us, for sure.
Dr. Sabik?
Well, first of all, I want to thank everyone. That was an absolutely fantastic session. I know I learned an awful lot. I actually have kind of a specific question, and it's something about the ischemia study that's just bothered me. You know, when we think about ischemia, right, it's conservative versus invasive. But in all honesty, all patients had an imaging study, a screening study, to see if they had left main. And it seems to me that that message has been lost, that patients can have moderate or severe ischemia on a imaging, on a kind of a stress test, and then we can treat them medically. But I wanted your opinion. Shouldn't they all have a CT scan to look if they have left main?
I'll answer that. Yeah, I think that the appropriateness of CT scanning is quite high now, and maybe Mike can say more about it, but that was a very important initial box on the treatment algorithm. Now, there were actually some patients with left main disease. It was discovered on the angiogram, and some people in ischemia did not have a CT scan. But yes, that was an exclusion criteria.
And so, but I suppose the follow-up, is it really a study of conservative versus invasive?
Yeah.
I mean, it's still a study that requires imaging of some type.
Right. Let me take it to the next level, translation. So now you have your patient in front of you. In the trial, you sent the CT off to Atlanta or to Cedars, and you had it read. But in the real world, you're going to do the CT, if there's neutrality in the finding, you're going to do a CT scan. Are you going to walk away with the president of Bank of America as your patient, and he's got, a 98% mid-LAD? I don't know. I don't think it is I think ischemia has failed on so many fronts. On so many fronts it's failed, from the peri-procedural MI definition to the design of the trial. And again, I think there are great lessons from ischemia. I'm glad we did it, but it's been misinterpreted. And again, even how we apply it, how do you apply it to the patient? Because you're not going to say to your radiologist, tell me if it's left main or no disease, and then walk away. No one's going to do that. You have the anatomy in front of you.
Well, that's what I worry about, because I don't think, it's being applied appropriately. It hasn't been translated to clinical practice, because I think the message has been, if you have moderate or severe ischemia, great, we can manage you medically. No, you need to have an imaging study, because that's the way the study was designed. But thank you.
Thank you. Dr. Busquets.
Those are great comments and a great session. Our exhibitors are awaiting and our refreshments out in the exhibit hall. Thank you so much, moderators, for running this great morning session. We'll see you in half an hour.